Hello guys, welcome back again. So from the last video, we talked a lot on the history taking and examination, right? So in this video, we'll focus on the 7-minute chat with the examiner. So we'll go through the mindsets and how to present your history and findings. I'll show you how I come up with all kinds of differential diagnosis, and then we'll talk a little bit about investigations and management. So how you phrase it and how you present it to the examiner so that you feel it makes them feel more structured. And at the end, I'll show you my good feedbacks from my resits, the one I passed. So first of all, the mindsets. So there are two important mindsets I think should be keep in mind when you are talking to the consultant. The first of all is that you should technically dominating the 7 minutes. So you should talk more than the examiner. So whenever they ask a question, you give them the answer that they want, but as well as some extra stuff into it so that they feel more satisfied. They get the free knowledge from it. Technically, the examiner has to examine all kinds of students in that day, right? So they won't really put 100% focus on you. So if you present with a strong aura, like with power and with confidence, then they don't really listen to what you are saying in detail, you know? But a small thing to be aware of is that don't talk too much and still leave them time for them to ask you, because there are few important questions that they have to ask for them to give you marks. So it will be differential diagnosis, investigations, and management. I knew it because in one of the stations when I failed my first Mosler was the heads assessment, right? I mentioned last time in the previous video where I had to talk to a dad about his daughter who was unconscious in A&E. I have to go through a heads assessment, like home situation, suicidal thoughts, things like that, and to check that whether the daughter is safe to be discharged. And in the questioning phase, I talked a lot about the heads assessments as well as the management. Examiner doesn't really have time to ask me the differential diagnosis, so he didn't ask me. There's no time for that. And he gave me 0 mark because of it. And on the feedback, it says that there's no time to ask about differential diagnosis. So that's why there's 0 marks. Which is, you can say it's unfair because I don't know that that's one of your questions that you have to ask me. And it's not my job to take his iPad and see what kind of questions I need to be answering. Leave some time for them and keep in mind that differential diagnosis, investigations, and management are the 3 questions that they have to ask you, at least have to ask you to give you the marks for the questioning phase, okay? The second thing to keep in mind is the tunnel vision. And this one is quite difficult because when seeing certain kind of patterns, it's easy to dive into it like very easily. So for example, there was a patient who the vignette says that he has an epigastric pain, and in the medication, he has been taking ibuprofen for long time without any PPI. So obviously, this sounds like a peptic ulcer, isn't it? And when the patient says that he has been vomiting, there's some muddy colors of it. Mud sounds like a brown color, so I thought that it's a upper GI bleed. And because of it, I was really fixed-minded, so I thought that it's like for sure like peptic ulcer lah, bro. Then I disregarded his other presenting complaints like constipations, quite a significant background of abdominal surgeries for Crohn's disease, I think. So as a result, the differential diagnosis was small bowel obstruction. There's not much way to tackle it because it's a more natural response to patterns. But I'll share with you my way of keeping with a broad differential and don't misinterpret what patient is saying. So the patient said that he has a muddy vomit. I tried to specify on what color it is, but he keeps on saying that it's muddy. So I thought he meant like blood or like a brownish color. So when presenting it back, I said there's bleeding in his vomit, which the examiner wasn't really a fan about it. He said that it's me like misunderstanding the patient's words. So aware of that and keep that in mind when talking about the differential diagnosis, okay? So going on to the first part where we need to start talking, okay? After talking to the patient, we need to start talking to the examiner, right? Some of the examiner will ask you to present the history to them. And this is the structure that I say. So they would probably ask you that, okay, so can you present the history findings, or can you present with the positive findings of the histories, things like that. Then you start with, this is, for example, like John, a 55-year-old male, present with, epigastric pain with vomits of muddy content, things like that. And he has a background of significant smoking history, significant alcohol history, as well as ibuprofen use without any PPI. So you can see that for the first two sentences, you say what kind of symptoms the patient is experiencing without that much of details, and you go into the background where you show the risk factors of it. So significant history of smoking or ibuprofen use, alcohol usage. That two sentences allow the examiner to know that, okay, so this guy has taken out the important bits from the history instead of saying that, oh, he has epigastric pain that radiates to the back, 6 out of 10 severity, gets better when drinking water, get worse when eating things. Those kind of details is too much. So keep it concise. And then the next sentence I usually use is no other symptoms like, so that it shows that you rule out other things. For example, like no other symptoms like fever, recent change in diets, no weight loss, no tiredness. So then you can see that it doesn't sound like there's no fever, right? So no signs of any infections, no change in diet, so no like food poisoning or gastroenteritis risks. There's no weight loss, so doesn't sound like any cancer. If there's any other relevant information, put it in, like family histories, like for example, significant family history of gastric cancer, then you can put that in. Then you'll go on to examination. So on abdominal examination, you first say like, oh, there's no peripheral stigmata of any abdominal disease, like liver disease. That will ease you on saying that, oh, there's no skin changes, there's no like hepatic flaps, there's no like conjunctival pallor, there's nothing like that. Just say there's no peripheral stigmata of any GI disease. Then that just saves you a lot of time. And then you go on to like arm palpitation, there's like general tenderness on here, normal bowel sounds, things like that. Last time I mentioned that you would say to complete the examination, I would do. So for example, like GI exam, you'll do PR, hernia, ophrosis, external genitalia. Just put that in as well. So therefore, it was a normal GI exam. To complete my examination, I will do this, I'll check this, I'll check this, I'll check that, whatever. And then even though sometimes the examiner doesn't ask you to put the differential, but just, I feel like it feels better so that they don't have to spend time asking you again what differential you have in your mind. So just say it like, oh, my differential are So this leads on to differentials. So when it comes to differential diagnosis, we know that we need to give quite a lot of them to, first of all, show off our knowledge, as well as showing them that there are a lot of things that we considered. So this is the part that I improved the most significantly. And if you look at my previous attempt and my current results, see that there's a 7-point improvement. So some people use the system called vitamin CDEF, right? And some people use just a system. For example, if you got a respiratory problem, then you think more of the respiratory kind of system, and then probably cardiovascular a little bit. But because of my failure, I was really scared. So I tried to combine both of them together, and I'll show you how to do that. So let's say we got a epigastric pain, right? We got epigastric pain. So first of all, we're thinking about it in the 3-minute prep time. we'll write down the system that could be going on. So like GI, vascular, cancer, I just put it at the side as well. And next, I'll go on to thinking about the condition that I learned about. This is a bit tricky, but overall, it's still a Mosler exam. So they will try to come up with the things that you learned about. So go through them has a quite a high success rate on finding what it is. So we learn about GORD, we learn about ulcer, indigestion is quite common, something we can quickly rule out, as well as pancreatitis. That's probably it. Vascular wise, even though unlikely, but then a rupture AAA could also cause epigastric pain as well. I know it's unlikely, but we could just say it, you know. And cancer wise, like gastric cancer, pancreatic cancer, all kinds of cancers. So that's the first set of all kinds of differentials that we have from the usage of system, right? The GI system, vascular system, and cancer in general. And then if we want more, then we go on to vitamin C, D, E, F to quickly go through it to see what kind of things we might have missed. So V, vascular. So any bleeding or any blood vessel kind of problems. So AAA, we got it. I for infections. So it could be like peptic ulcer or like H. pylori infections, right? And trauma. Trauma could be, like I've seen a patient in 3rd year where she was kicked by a horse and there's like a massive hole in her stomach. So obviously that'll give us a epigastric pain. Autoimmune, I can't really think of it. Metabolic, not really much. Iatrogenic, like NSAIDs, steroid use without any PPI, could be it. So we could quickly check it. Neoplasm, cancer, got it. Congenital, not really. Degenerative, not really, yeah. Endocrine, yeah, I mean, if it is quite a vague abdominal pain, like a general abdominal pain, or not really localized to epigastric, but quite a vague general presentations, it could still be like Addison's disease. So just keep that in mind, you know, you don't really have to ask a lot of questions on Addison's, like any bronze skin changes, things like that. Just keep that in mind. And F for functional, not really. Like mental health, if nothing is going on. So that's a way of coming up with a lot of differential diagnosis. And in terms of the system wise, I have listed out like neurological, ENT, thyroids, cardiac, respiratory, GI. And GI wise, I also taken out the liver part as itself, as well as kidneys. So I usually forget like kidney stones, pyelonephritis, urology, so like UTI, cystitis, MSK, yeah, skin, vascular injury, cancers. In terms of the vague ones, it's just something to keep in mind that they can present in all kinds of symptoms. So like hematology, like tiredness, weight loss, very vague, like a lot of infections recently, such as like leukemia or multiple myeloma, like calcium raise, like back pain, things like that. You wouldn't even think about it unless you check your bloods. Immunology, connective tissue disease. Yeah, connective tissue disease involves a lot of skin, MSK problems, or general tiredness. SLE can also lead to like miscarriages. So if you think it might be going on, also check that. Endocrine, so like Cushing disease, Addison's disease, could present like full body presentations. So that's why you could briefly touch it if you think it might be going on. Gynae, obstetric, and mental health is just something in back of your mind that could be going on. Obviously, it could be combinations like COPD plus asthma, or asthma plus heart failure, leading to an even worsened shortness of breath. But it's really unlikely for an exam to come up with multiple things because they'll be quite harsh, isn't it? Something to consider is the cause and triggers and why it happens. So sometimes, for example, like exacerbation of COPD, that's a diagnosis, right? And then you can also say it's secondary to bacteria or virus infections, but that's just something to keep in mind. it doesn't apply to every single medical conditions. You're not going to say like multiple sclerosis secondary to something, something, something. And finally, when it comes to telling what kind of differentials you have, just say why you think it could be. So for example, rheumatoid arthritis. Okay, so rheumatoid arthritis, my top differential will be rheumatoid arthritis because there's an early morning stiffening, multiple joints, and red hot swollen, which is quite chronic presentation, as well as the joints is usually on the MTT is here and then PIP here. Then that does make sense to the examiner. They'll understand that, okay, so this sounds like a rheumatoid arthritis if he's on the phone. Second differential would be osteoarthritis because multiple joints, the patient is quite obese, that's a risk factor, things like that. And you can also say that it's unlikely because, so it's unlikely because it doesn't involve the DIP joints, which is more common in osteoarthritis. The third thing is and other things you can say like some minor things that you think might be going on or could be easily checked. So for example, like like a fracture, like a reactive arthritis, even though there's no recent gastroenteritis, things like that. So like you tell them why you think it this way, your thought process, so that they could give you marks for that, and they won't deduct you for random reasons. So investigations wise, previously when I talk about investigations, I often get interrupted in the middle. So for example, I'm talking about bedside, and then the examiner will be like, okay, so what kind of bloods will you do? Which is sometimes a bit annoying because I'm not there yet. So to prevent that from happening, you could say like, I'll split my investigations into bedside bloods, image, and special tests, so that they will understand that, okay, so now we're talking about bedside, we'll talk about blood later, so I don't need to interrupt the student in the process. And you will also say what you're looking for as well as what you're trying to see. And your aim is to obviously roll in, roll out, or monitor the stuff that you're trying to find out. So for bedside wise, you could say like, oh, I'll do other clinical examinations. So for example, if you think that this patient has a heart failure, you did the cardiovascular exam, right? You could also say that, oh, I'll do a respiratory exam just to complete the examination, things like that. And sometimes if the patient is quite in an urgent situation, like for example, Parkinson's disease, who had a swallow difficulty, then you could say you will do a A to E assessment as well. That shows the examiner that this is quite an urgent situation. You need to examine the airway quite properly. Sometimes you will check the cognitive assessments, such as for dementia, right? Other things for bedsides are like this. So OBS, so blood pressure. Sometimes blood pressure is very important, ascending, sitting, temperature for infections, urine dip, BM, swabs, ABG, ECG, scoring for severity, so some like special scores. For example, Glasgow score for pancreatitis, I think. Yeah, I think so. Going on to the bloods, so common ones, I wrote down some reasons for you to say. So for blood counts, you could say white blood cell counts for infections, even though you don't think this patient has an infection, but you can still say it's just to rule out any infections. That's quite a smart way of doing a full blood count, because we're still gonna do it, and they always want you to have a reason behind it. So that's quite a good reason for that. Or anemia, platelets for bleedings. Use and needs and RFTs. You can either say use and needs imbalances, which could lead to a lot of different things. For example, like muscle weaknesses. Or you could say use and needs and RFTs for medications. So we're going to provide some medications in the future. So just to check the kidney functions and liver functions. That's quite a good reason. And CRP obviously for inflammation, right? So calcium, magnesium, those kind of things. The special markers, don't forget, because those are the most important ones that you want to include. So the regular ones, you want to have quite a justified reason for that. And don't forget the important ones. So for example, PSA for cancer markers. I often forget after going through a long paragraph of why I'm doing full blood counts, use any of these. Very scary, yeah. Image, there are some special images like PET scan or MCUG for atypical UTI in PET. So those images, have a look and make sure you don't miss them. And by the way, let's say we have a meningitis patient, right? And our differential is, or my top differential will be meningitis, subarachnoid hemorrhage, a brain tumor, and then other differential will be encapsulitis, GCA, things like that. Then for the investigations, other than the specific investigations for meningitis, which is lumbar punctures, still say like the other investigations for the other differentials that you mentioned, so that you can rule them out. And that sounds quite obvious, but then I often forget on it because I'm focusing too much on my top differentials. So in other words, meningitis, we do lumbar puncture, right? And bloods to check for any raised inflammatory markers. Brain tumor, we do CT scan and like GCA. If you think that it's a GCA, you could also say like, even though unlikely, but we could still consider doing a ultrasound as well as a biopsy on the arteries over here, so that the examiner know that you're not going to do it now, but then it's still something to consider if meningitis is not the cause of the current situation, right? So special ones, just lumbar puncture, biopsy. I know EMG could be one of them for myasthenia gravis. Okay, so going on to the management. So management wise, just in case the examiner is going to interrupt you, say it this way, so that I'm going to split my management into conservative, medication and surgery, or if it is a mental health problem, then you can say that we'll do the biopsychosocial model to manage this patient so that they won't interrupt you in the middle. And then before that, remember that if you think that this patient has a cancer or some important things, we need urgent referrals. So for example, there was a patient in my first attempt, which is 60-ish or 70-ish female with a postmenopausal bleeding, and examination was normal, so it is unlikely to be atrophic vaginitis. So what we're thinking is endometrial cancer, right? So when it comes to management, the consultant asked me about the investigations. So then we need to put in the investigations in our management, okay? So don't miss that. You can say like, oh, so first of all, we'll do some investigations, bedside, blood, image, and special tests, or referral, and then say something about each of them. And then go on to management, or do conservative, medication, surgery. And in terms of management, just remember that there's the short-term and long-term maintenance, as well as the prophylaxis. One of my second attempt was a stroke patient, a stroke follow-up patient, and the examiner was asking about the management. So I asked him like, which one? Do you mean the acute one when I first see him, or do you mean the maintenance one? So he said both. So that would be a long paragraph. Be aware of this concept of management. There's the short-term acute ones, for example, like myocardial infarctions, MI, ACS. There's the short-term, there's the MONAD, right? Morphine, oxygen, aspirin. Long-term maintenance will be like ACE inhibitor, atenolol, things like that. So double check with the examiner which one he meant, or just say both of them. Actually, conservative management has a lot to be included. So it'll be the background support. They love MDT, right? So you will say that we'll involve MDT support in this patient's management. For example, this is this specialist, OT, PT, ST. So OT will be occupational therapy, ST will be SALT team, so speech, and then PT will be physio. And then some information about social groups, mental support if they need, follow-ups, leaflets. Those are the background support. Lifestyles, education, so let the patient know what condition he has. And sometimes pain management as well as anti-sickness can be considered as conservative. Or if you want to put it in medication, that's also fine as well. Medication-wise, just tell them what kind of medication you want to give them. If it is a specialist drugs, let the examiner know as well. For example, like multiple sclerosis will be natalizumab, right? You say that, oh, specialist drug, natalizumab. And for certain side effects, if they ask you, just be aware of it. For example, Addison's disease. You need long-term steroids, right? So then that'll be don't stop. So do not stop at any time. Steroid cards, treatment cards, osteoporosis, PPI. Just be aware of certain side effects of your management. Surgery, be aware that they might ask you about some specific knowledge about certain surgeries. So for example, I got asked about mitral valve replacement and the INR for warfarins. I don't know, man. I didn't do well in that station. The examiner didn't give me quite a high score for that either. I heard about people examining the stoma bag and the colorectal cancer as well as the surgeries for that. I heard people being asked about breast surgeries, like breast conserving surgeries, mastectomies. So if you got some time, double check on that. They might come up with the condition itself. So overall, that's the general questioning phase and things you'll be asked about. So going through my feedbacks on the second attempt, the station 1, you can see that the pathway is okay. What's this? Oh, this is a stroke. Yeah, this is a stroke one where he asked me about the management. He said to explain the acute management as well as the long-term management. So the long-term management. This one is the one I said to be aware of the tunnel vision because I thought that he had a epigastric bleeding, but it's actually actually a small bowel obstruction because of the quite a significant bowel surgeries causing adhesions and a constipation. So this one is explaining grammar about the management of atypical UTI for peds. Oh no. So this one is explaining GDM and the management. I missed the part on the conservative lifestyle management for that, but overall it was okay. You can see how it is explained. Okay, nothing much. You see that, yeah, highlights the involvement of the specialist, which is okay. This is a Crohn's disease patient. So I mentioned about the other than steroids, we can give those specialist drugs like azathioprine, which is more specialist drugs. This one, good management plan, nothing much. Differential diagnosis, I mentioned last time, I didn't really do well on the examination. I thought I failed it, but actually I didn't. And you can see that my presentation, the summarizing, doesn't really have that much of a confidence because I don't know whether I felt it or not. I had quite a lot of repeating and then adding things on after I went through the presenting complaints, which is why there's a feedback on I need to practice it more. This one is the panic attack, and the the management plan, I mentioned about biopsychosocial models, which is quite well-rounded and holistic. So the examiner quite like the idea of it. This one is A2E assessment. Doesn't really matter that much. So yeah. So okay, so that's everything I know about the 7-minute interrogation periods with the examiner. We talked through about a lot on the structure of presenting your histories, as well as the differential diagnosis, how to come up with them. We went through the investigations and management, and the importance of saying the structure beforehand so that they don't interrupt you. We went through a little bit on my feedbacks, and generally it's quite okay. Like, there's not much of a major issue. In the next video, we'll go through the A2E assessments. And if there's any questions or concerns about the questioning phase, feel free to comment below or ask it in the Google questionnaire. Thank you for watching, and I'll see you in the next video. Bye!